go, Alan.
We can start?
Yeah.
Terrific. Okay. Thank you. Thank you very much. Good evening, everyone, and welcome. My name is Alan Odette. I'm the CEO of the Ontario Medical Association, and it's really an honor for me to be here tonight and to be asked to start the evening's events. Tonight's discussion is about health inequities faced by Indigenous communities, and we'll begin with an acknowledgement of the land that we're on, with recognition and respect for the traditions and the people who were here before us. I'm joining this event, although virtually this evening, from the unceded and ancestral territories of the Anishinaabe, the Chippewa, the Haudenosaunee, the Mississaugas of the Credit River, and the Wendat. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and I'm grateful to have the privilege to work and live on this land. Out of respect for the rights of Indigenous people, it's our collective responsibility to recognize our colonial histories, present day implications, to honor, protect, and sustain this land. Tomorrow is National Day of Truth and Reconciliation. It's an annual day to remember the lost children and survivors of residential schools, their families, and their communities. It is also an opportunity to learn more about Indigenous issues and reflect on how we, as allies within the healthcare system, can do better, and we can do better. Tonight is about using the collective Ontario Medical Association voice to draw attention to the long-standing health care challenges and toward some solutions. Our prescription for health, a doctor's 5-point plan, aligns with the call to action released by the Truth and Reconciliation Commission of Canada, specifically in our recommendations: improve equitable access to care, ensure healthcare is culturally and linguistically safe, address social determinants of health, address the impact of the opioid crisis and mental health issues, focus on innovative, collaborative, and culturally sensitive training for physicians in rural and remote communities, and address among the most significant issues, and that is safe drinking water for everyone. Recently, we've had a chance to meet with the Indigenous Primary Healthcare Council as a member of the Primary Care Collaborative in developing a soon-to-be released policy paper on mental health. It recommends the implementation of an Indigenous-led mental health and wellness strategy for this province. OMA President Dr. Rose Zacharias also recently met with the team at NAN, and I'm very pleased to hear, I believe May Cat from NAN is here in the audience tonight, and I was told that they described seeing their community in the many recommendations in our prescription for Ontario. During the meeting, they spoke of intergenerational trauma, difficulty of trusting healthcare providers, and shared feelings of racism and inequity in the healthcare system. These are issues that are very important to the OMA. They're very important to me personally, and we're committed to listening, learning, and using our voice to address these issues. It's not possible to do justice in 60 minutes, but the hope is that the panel discussion will spur some more discussion and action by you, your colleagues, and frankly, across the broader healthcare sector. I know that the discussion tonight will be meaningful, and as we hear from our panelists, I'll have an open heart and mind and reflect on what I can do as Alan Odette, and in this unique position that I have as the CEO of the Ontario Medical Association, I actually have a really significant opportunity to contribute. Another time, I'll share some of my experience working in First Nations and Aboriginal communities. And while this isn't on my script, I'm going to share it anyway. I needed a 100 year course to complete my undergrad. I won't tell you how many years ago, because it's quite a few years ago. And I had an opportunity to take an introduction to Aboriginal affairs at Trent University one summer, where I met a professor. His name was Norman Gull. He was from James Bay. And I learned more in that one summer course than perhaps any other course that I took during my undergraduate. And I am forever in debt to Norman Gull for the time that he took to help me learn and better understand some of the history in this country as it relates to the First Peoples. I'm excited tonight that we have a very distinguished award-winning journalist and author, Tanya Talaga. Tanya. For more than 20 years, Tanya was a journalist at the Toronto Star. I've been watching and reading you for years. She's been nominated for 5 times the Meechner Award in Public Service Journalism. She's written 2 national best-selling books and holds 5 honorary degrees. So before I turn it over to Tanya, I just want to remind everyone that this event is being recorded tonight, and it'll be made available for others who might not be able to attend this evening on our Ontario Medical Association website, Miigwech. And I'll pass it over to you, Tanya.
Bonjour. I'm very grateful to be here this evening. Tanya Talaga Nigisnikas, Ka Musko Pimujije Pinishish Nigisnikas. I'm coming to you today from my traditional territory of Fort William First Nation. I am on the shores of Thunder Bay's Lake Superior, and I'm very happy to be here tonight. And I know we have a big run of show this evening. We have an hour. We have so many incredible Indigenous physicians to hear from today, and I want you to really listen to what they have to say. And so I'm not going to say very much because we're already 1 minute behind, and I'm going to get all stressed out considering we've got a very tight run of show right now. So I'm just going to say a couple things. Very quickly, I'm glad to hear that May Cat is in the audience tonight. She should actually be the one moderating and asking all the questions here. She could give you an absolute bird's eye view of what it is like in our northern communities without access to doctors, to x-ray machines, to medical care. And she will tell you that if you actually want to access any services, high-level medical services, see a psychiatrist, you have to get on a plane and travel 500 or 600 kilometers away and come into city centers like Sioux Lookout, Thunder Bay, Timmins. But I'm just going to share one thing. 2 things. Quickly, why I said I would absolutely make the time to be here today is because every time I get the chance to speak to doctors, I love to do that. I love to tell doctors what I have seen, the stories that I've been honored to be gifted to share with you. And every time I am in Thunder Bay, and it's in September, I think of 21-year-old Craig Neekin from Echequan First Nation. I met Craig's father over 4 years ago now, this time of year, and I met him outside of a hotel here. And it was late one night. We just got off of our flight, and his father, Craig's father, Troy, introduced himself to me. And we struck up a conversation, and he told me that he was in Thunder Bay to retrieve his son's body. He was in shock. He was very upset, didn't really know which way to turn. And he said to me that his son was brought into the local Thunder Bay Regional Health Sciences Hospital for mental health care. And instead of being seen by a physician, he was escorted off the property by security guards. And Craig took his life across the street from the hospital. This is one very tragic example of what it is like to access healthcare in our communities. And I'm sure everybody on this panel will be able to tell you a story that is quite similar to that of Craig Neekins and of the cascading effects of lack of treating mental health care means to our people. I shared this with the doctors beforehand, and I'll just tell you quickly now as well that that Craig's father, Troy, who I originally met 4 years ago, he also took his life because his grief was just too much over the loss of his son. So you see the cascading effects that we have in our communities, in our families, just from lack of access to health and medical care. I'm saying this tonight too because it is the 2-year anniversary of Joyce Echequan's death. As you know, she was a mom of 7, and she had gone into a Joyceville, Quebec hospital to receive health care, and she recorded live her treatment, what was happening to her, and the racist comments she was experiencing before she passed away. She broadcast it all over social media. So keeping them in mind very much this evening about the disparities within, as I call it, 2 Canadas. One Canada for non-Indigenous people and one for Indigenous people, and the vast gulf that exists in trying to access healthcare. But there is no one else that could actually tell you more about that than the person I'm about to introduce, Dr. Alika Lafontaine. He is the Lafontaine, I should say. Sorry, I always forget the La in front of Fontaine. Dr. Lafontaine is the very first Indigenous president of the Canadian Medical Association. I am delighted to introduce you to him, and I'm going to turn it over to Dr. Lafontaine so he could give us a few opening remarks.
Yeah, thanks so much, Tanya, for sharing that. And I remember hearing about that story when we were working with Anishinaabe Aski Nation as part of the Indigenous Health Alliance. And, that and other stories, they remind me why it's important to have these types of conversations. I was thinking of what to share today, and I'm just going to share 2 things. The first is a teaching that was shared with me by Ted Cusance. He was a past chief of Kiskous First Nation in Saskatchewan. I grew up in Regina and Saskatoon, Treaty 4 territory and homeland of the Métis. And Ted was helping us to work through some of the issues with the Alliance early on. And he told me that there's a lot of people that we're going to come across who want to share their trauma, but if they don't share it, it's because we're not ready to accept it, not because they're not ready to share it. And I've thought a lot about that as I've had conversations with my kids leading up to National Day for Truth and Reconciliation. And I think one of the things that keeps on coming to my mind is that as an ally, it's important to realize that it's Indigenous people's truth, but it's your trust. You have to trust then reconcile. There are thousands of stories of racism that I've heard over my career, which means that there's thousands more that I haven't heard. And when I hear about, the experience of Joyce Echequan and the fact that she felt the need that she had to live stream on Facebook her experience for people to believe that this was happening to her, it's a reminder that we still don't honor the stories and lived experience of people who are going through these horrible experiences. The reality of racism within healthcare is that very, very few people actually share it because it's not a cost-neutral activity. You share an experience of racism, you often lose your provider. You get things attached to your chart that make other providers very hesitant to engage with you, which can make it very difficult to get into the system or through the system as you get the care that you need. Imagine a patient in a rural or remote community that only has a physician who comes through for a few days per month, has a horrible experience with that person. If they say any sort of concern, that could change the whole character of care. Suddenly that person doesn't want to see them, that person doesn't trust them, that person doesn't share with them, and they have no recourse because of the way that we've set up our health system. And so I just impress on the people listening today, if you're an Indigenous person, reflect on your own truths, but if you're an ally, don't forget, you have to trust in order to enter onto that path of reconciliation. Thank you.
Miigwech for your words. Um, I would like to introduce Dr. Suzanne Shush right now. Dr. Shush is an incredible Black and Indigenous physician. She's an auntie. She is a family physician, an Indigenous health faculty lead at the University of Toronto, Department of Family and Community Medicine. I could read you as well her full bio and all of the things she does. But as an Indigenous person myself who lives in the city of Toronto, I'm very grateful to have someone like Dr. Shush in my realm and taking care of all of us. And so, Dr. Shush, I would like to turn it over to you.
Oh my goodness, thank you so much. Honestly, I thought it was going to be hard to follow Dr. Lafontaine, but that's even harder to follow, Tanya. You are so appreciated for all of the work that you do in the community. So I'm Dr. Shush. I am, like Tanya said, I am a Black and First Nations physician. I'm also a mother. I'm an advocate. I am an absolute auntie in the community. On my mother's side, I'm an intergenerational residential school survivor. I'm also currently a student. So I'm actually doing a master's degree right now at the University of Toronto, IHPME, trying to look at modeling the impact of spreading both infectious disease and trust through the Indigenous community, and how those two aspects can work together to really impact the way that both health information, health interventions, and illness and wellness can spread. I think that it's really important that we're having this discussion. When we're looking at the idea that we're here to try and understand health disparities in Indigenous communities, everyone has already said this incredibly well, that this is really a tale of two Canadas. And without understanding really having that baseline understanding of the alarming depth of these inequities, and these are inequities in all aspects of our lives, and really knowing that there's very specific reasons that these health inequities exist, and therefore we need very specific solutions to solve those health inequities. We're looking at really like a centuries-long intentional process of disenfranchisement, of devaluing, of making Indigenous people worth less. And that means, the breadth of anti-Indigenous racism impacts every aspect of our life, where you're devalued for your culture, your language, your parenting, your appearance. Really, every aspect of your life is going to contribute to poor health outcomes. And I think that there's very clear reasons why somebody like Dr. Odette, who's clearly well educated but didn't learn about Indigenous health inequities until he was in university. There's very clear reasons that people who are non-Indigenous tend not to have colleagues and friends and circles and teachers, employers, or anybody in their life that is Indigenous. There is real segregation that has come out of the Indian Act and that has come out of these centuries of marginalization. And when you look at the fact that that story you opened with, I just feel sick to my stomach thinking about it, because it is the reality of every Indigenous person that seeks care. When you are going to get care, or whether you're going to access any service, it doesn't have to be a hospital, but when you're accessing housing, employment, education, but absolutely healthcare, Indigenous people have to anticipate the racism that they're going to face, and then strategize ways to overcome that and to mitigate that. And that might involve delaying care, that might involve preventing care, that might involve not seeking care, that might involve trying to find a solution by yourself at home, that might involve self-medication, that might involve suffering, that might involve untreated mental illness, that might involve untreated chronic illness. And when we see the impacts of that in our healthcare system, like Dr. Lafontaine said, we need to have trust so that we can improve health outcomes. And we're not there yet. We're not close to being there. And I think that, one of the things I think about quite a bit is your book, Seven Fallen Feathers, and the impact that book then had going forward to make real concrete social change in Thunder Bay with the dismantling of the Thunder Bay Police Services Force. And I think that one of the most profound and important notes to come out of that Operation Broken, or the Broken Trust, or PIRD report, was the idea that it is your fault for not recognizing inequities. It is your fault if you're failing to be aware of anti-Indigenous racism, and it is your fault if you're failing to close those gaps and address those issues. If you are a hospital CEO, if you are on a board of a hospital, if you're in leadership in any way, shape, or form, I want I want that report to be burned into your brain. You need to be aware that if somebody comes knocking and Tanya does an expose on our hospital systems, and somebody wants to know what you have done in order to promote reconciliation and close health gaps, your answer can't just be, oh, I didn't notice anything was happening, but I didn't do anything wrong. You can't just take a system that is historically racist and do nothing about it and expect that equality will just come out of that. And I think that we really have to start recognizing that Indigenous people have solutions. We learn nothing for a very long time about Indigenous people. And then we just learn the disparities. We just learn the gaps. We learn this very deficit-based view of Indigenous people without understanding the strength of the kinship systems, the strength of the knowledge systems, the strength that we have within our community. And if you tap into that, Indigenous people have solutions to issues that the healthcare problem has so far been unable to solve. And the healthcare system as it stands is unable to solve them because it's actually part of the design. So the outcomes that we see are by design. We require innovation. There's like a big buzzword around the word social medicine. Social medicine is just problem solving. And we need to remove the word no from the vocabulary of anybody that Indigenous care providers speak to. I've faced the word no over and over and over in trying to develop innovative systems, innovative solutions, work with the community, be community-based, actually create, a system that truly is welcoming and safe and that works for our community. And I think that we can start trying to shift resources to these Indigenous people, to these Indigenous communities who do have answers and do understand. And I really, my God, that remark that you say about not wanting to be that person that shares the experience is so frustrating for me to hear that, because that is a pervasive issue that just perpetuates the ongoing harm that happens in our community. And it's something that I struggle with all the time here in Toronto, being one of the only Indigenous physicians here in Toronto. I answer to the community. If the community calls me for poor care, then I have to be the one that turns around and makes that call to the ICU. And it hurts my heart. It's embarrassing for me. And even though it shouldn't be, I feel like I'm being obnoxious, or I'm stepping in, or I'm questioning somebody's abilities. But those are the things that have to happen. And I think this is hard for me to make the call to confront somebody that's getting poor care. Imagine how hard it was for the survivors who came before us to live through this. Imagine how hard it is for people to speak through this. And then imagine how hard it is for the patient who's experiencing that poor care. And I think that we can all be allies. We can all listen to those voices, and we can all just be very, very open-minded and kind when we're hearing the truths that people are willing to put forward. And if I'm blessed enough to be a receiver of that truth, I hope that I can use that to improve care and improve, futures for our people.
Miigwech. Thank you so much, Dr. Shush. I told you that she is a dynamo. Okay, so Dr. Benjamin Lalonde, you are next. Dr. Lalonde, you are from Marathon, Ontario. And Marathon is just down the road here from Thunder Bay. You are a proud Indigenous physician from Northern Ontario. And you, as well, are the Chief of Staff at the West Nipissing General Hospital. And you also provide addiction service medicine in Sturgeon Falls and North Bay, Ontario. And I'm delighted to actually read in your bio that you've been designated as a founding Chief of Staff of the largest new addiction treatment center in Northern Ontario, slated to open in 2023. That is huge, and so needed. And I am delighted to turn the floor over to you.
Thank you for those kind remarks. Thank you for everybody for being here and listening. I feel like as if Dr. Shush and yourself and Dr. Lafontaine kind of set up what I wanted to talk about, just because I think that it all kind of blends into the same message here. So I do have like one picture that I was hoping that can be brought up. So whoever is in charge of doing that can do so now. This picture really illustrates what I think that what everybody is ultimately trying to talk about. Where we are now is where the greater Canadian population thinks we are now is in this on the left side here, where everybody's being treated equally and everybody should have an equal opportunity. And why can't Indigenous people just get better? Why can't we just make it work? And I think that there's a very big disparity between understanding what equality is and equity is. And we've talked about this at the start with the opening remarks and all that. If you're worried about trying to get drinking water, if you're worried about trying to just manage the basics of life, you're not worrying about trying to make applications in medical school. You're not worried about trying to become physician or nursing leaders. You're not worried about trying to do that kind of thing. And then all this other stuff that can't happen. I hear the terrible stories in Thunder Bay, and I'm aware of the racism there. And I can tell you right now, and I can't guarantee there'll never be racism in my hospital, but I'll tell you, as the chief of staff, it won't happen very much in my hospital. Why? Because I'm the chief of staff. And why does that matter? Because my mother, who went through really bad residential school system, had to fight through all of this. She had to jump that fence. She didn't have people lift her up. But she got me in a position where I can actually be in a position to make change. I can actually be in a position to help inspire future people to be there. I was very proud this morning. I was sharing with the panel before the start of this because I was interviewed today by CTV News, and my wife took a picture of it, and I was talking about trying to get Indigenous youth to go into healthcare and to try and be leaders in their communities, because it's an honor to help my community. And there's a picture of my son watching, and I'm like, that's the goal, that's the point. And so truth and reconciliation to me is really about trying to change it from thinking about equality and thinking, okay, well, racism's fixed, even though it's not, to, okay, how do we get it so that everybody can succeed? Because I'm very aware of the fact that if we're not careful, there's a lot of bitterness amongst our people, which is warranted. But really, it's about trying to bring everybody up. It's about trying to bring the entire Canadian population up. Because if Indigenous people are doing better, then the whole world is doing better. And that's just something that I believe in. And ultimately, the ultimate goal is that we go to the far right side of that picture, where we can all just get along, and we can all respect each other and actually have an understanding of where things are. I'm aware of the time right now, so I don't want to talk more, even though I have so much more to say, but I'll send it back to you, Tanya.
Okay, Miigwech, thank you for that. I would love to talk more, and I'm sure we'll get into some of what you were saying, I hope, in the next half an hour. But before we do that, we have to introduce our last speaker, Dr. Chase McMurren. Dr. McMurren lives in Takaranto, and he comes from Lethbridge, which is Treaty 7 territory. And Dr. McMurren said he feels privileged to practice medicine and provide integrative medical psychotherapy, primarily for physicians and artists struggling with grief and with trauma. And I am delighted to have Dr. McMurren here as well to speak with us. Dr. McMurren is also, you should know, he is, oh my gosh, he's got such a big again, bio to read, but he is with the Faculty of Medicine at the University of Toronto as well. And so without any more delay, I would like to turn it over to Dr. McMurren for your remarks.
Kinanaskomatin, I think, and honor you, and I'm so honored to be here among such wonderful people, and grateful for this space. For us to be talking about these issues. I'm really struck by the reality that less than 1% of physicians in what we call Canada identify as Indigenous. That stat might be a little, I'm sure there's a bit more precision available, but that's sort of the last I checked. And about the same percentage of faculty at the University of Toronto identify as Indigenous. And I don't think that's not on purpose, and I acknowledge that in getting to practice colonial biomedicine, I've been trained in a colonial institution that specifically excluded Indigenous people on purpose, and worked really hard to limit the impact and the power of Indigenous people in what's now called Canada, in the attempt to create a Canada that would be welcome to settlers. And I think it's sometimes difficult, at least for me as a practitioner, to reconcile, or to attempt to reconcile, the fact that in getting to do the work I do, there's high risk of harm and the way that I was taught to doctor or to practice medicine is harmful, right? And specifically leans on narratives that are not healthy for I would say most people, but especially for Indigenous people. And so I want to name that the hidden curriculum is very alive and well, whether we see it or not, and that I haven't met many physicians who aren't really wounded, no matter where they come from, no matter where home is. And I think that the fear that comes up in considering truth and turning toward it, and considering reconciliation and the labor and care involved in earning someone's trust is quite scary for some. And I think I really hope that people can consider what's required for them to develop the courage and the commitment to turn toward what's uncomfortable. I think there's research about a curriculum of difficulty or of discomfort within medical education, and I think that acknowledging how uncomfortable it can be to talk about unimaginable disparity requires a lot of courage and a lot of willingness to sort of lift the curtain and ask where we learned what we learned and why we're still doing it. And so when I heard the horrifying story about the family in Thunder Bay and the impact of racism on so many, thinking about the cascade, makes me wonder what each of us would have done if we were working in the Emerge that night, and what got missed or what was not acknowledged. For me, I hear often about people being too busy, or that there's just too much going on, or that this or that people often are very good at explaining why things went wrong. But I wonder, like, what would you do? What will you do tonight if you're working a night shift, or tomorrow, and how can you do what needs to be done to acknowledge your role in reconciliation, and specifically in terms of earning trust and what it means to do that difficult work of earning someone's trust, and asking what that means to make that possible, mindful that it's up to the person or the patient to determine whether they feel we're safe or trustworthy or not. So no matter the amount of training we might do, it's really a work of learning to be humble and acknowledge that there's always more work to be done. So I'll pause there.
Dr. McMurren, thank you very much, Miigwech, for your words. Very considered comments, and very thoughtful comments too. And I was going to ask Dr. Lafontaine the first question for our panel, but I think that Dr. McMurren, you've actually asked the first question, and it's not unlike what I was going to ask Dr. Lafontaine, and that is, like, what if you had a Craig Neekan come in and you were working in the emergency room that evening? You should know that Craig came in by ambulance, and that he had been drinking, but as far as the medical reports say, he wasn't violent. He wasn't acting up or anything. I don't know much else about it. I can't really recall at this moment, but that is what I know of what happened. And I know that he spent less than 7 minutes in the ER before security guards took him out. I don't know if you mind answering that question. I would love to hear actually from all of the panelists on what they would do if they were working in the ER that night. I mean, how do you handle that? I mean, what if you're the only one there, right? And that's like your triage, it's crazy. What do you do?
Yeah, I might start the panel off just by answering that question. And I think that is a question that should be going through the listeners' minds as they kind of hear the comments from today. I'll answer the question for everyone. You'll do whatever you'd usually do. There are these collections of norms that exist within our environments of practice that we follow mindlessly, right? Someone comes in and they have slurred speech. In some places, they'll assume that that's diabetic ketoacidosis. Other places, you'll lean towards stroke. Other places, you'll lean towards alcoholism or a heart attack. We are trained to use bias as a way to expedite care and separate those who should be treated versus those who don't. But I think what should come across very clear from this discussion is our bias can often be very, very wrong. And we're taught to believe certain things about Indigenous patients, that they're predisposed to certain types of addictions, that they don't care about their health, that they overuse the health system. And, I was thinking about, Joyce during the comments, and the most terrifying part of that whole live stream for me was at the very end where the person is looking into the camera and they realize for the first time that they've been recorded and there's no fear on their face. That was the look to me of someone who did not expect to get into trouble for what they were doing to Joyce. And I think that's a moment for us to sit back and reflect. We are swept up in the currents of what's normal within the systems that we work in. And if we don't deliberately intervene, those norms take us over and they take over the people around us. And so I do think there's both conscious and unconscious racism that exists in the system, but it's just as harmful whether you pay attention to it as if you don't.
Wow, that's incredible. And so well said. And I did, piggybacking on that, I wanted to ask you and wanted to ask the other panelists this question as well. What has changed in the 2 years since Joyce's death? Anything?
I don't think a lot has changed, if I'm being 100% honest. I think we're still caught in the pre-contemplation stage of dealing with problems. I do think that we've made gains in being able to talk about racism openly. I think we've made gains that it's no longer acceptable just to dismiss an accusation of racism. You actually have to confront it. So I think there is social movement towards having these more open conversations. But as far as those big moves, like the ones that you lean in and actually make a difference in people's day-to-day life, that might be happening in small pockets, but I think we have a very long way to go with having Joyce's life making the change that I think it needs to.
Miigwech. Dr. Shush, what are your thoughts on on Joyce and what, if anything, has changed in the last 2 years?
I loved that answer that Dr. Lafontaine just gave. I think that it is really, really, really important. The reality is that you do what you always do. And what you always do is driven by bias. And what people don't necessarily put together is that bias has an associated emotional response. So a positive bias will make you feel warm and loving to that person, and a negative bias will make you feel disdainful or contemptuous or disgusted. And we know that for so many people who work in Emerge, so many people who work in frontline patient-facing care, there's already levels of job dissatisfaction from having to see certain types of patients. And those types of patients are ones who are using substances, who are homeless, who are Indigenous, who you can make assumptions are all three. And then when you allow that bias to trigger that emotional reaction, that disdainful, contemptuous reaction, you're going to make a decision that will actually kill the patient. And we're seeing that play out again and again and again. And one of the things that I would like to see is a model that's set up where you don't actually have to wait until the moment that this person is in crisis to make the first point of contact with the healthcare system. Why does his first point of contact with a healthcare system have to be when he is on the verge of suicide, on the verge of death, on the verge of catastrophe? Why did that have to be the moment that he came into contact? Why was there not a place that he could have gotten care, where he could have had a team of aunties looking out for him, somebody to talk to, somebody to make him tea, somebody to sit down, somebody to accompany him to the hospital, somebody to sit there with him, somebody where there's this familiar face and this warm handover. Like I was recently at a street medicine conference, and the chair of our DFCM was talking, and she was saying, unfortunately, we don't have a model, that she was referring to street medicine. She was like, unfortunately, we don't have a model of care set up in this province where you can miss 5 appointments and show up 6 hours late to your 6th appointment, and our response is thank you for coming. And I was like, what? That's like the exact model that we have. Like, that's exactly the model that you have. And you can have these systems. And again, it keeps coming back to, we do need to see change. We do need to have innovation. We do need to shift to social medicine. We do have to shift to accompaniment. And, with the death of Joyce Echequan, and I can't believe it's 2 years, it partly feels like it's ancient history and partly feels like it just happened. It's this strange moment in time. I feel like I took advantage of that moment. The second that our CEO of my hospital that I worked at wrote this very beautiful email to the entire organization, acknowledging and lamenting and expressing frustration, and acknowledging the widespread nature of systemic anti-Indigenous racism, I was ready with a reply. Okay, good. Now let's look at this policy. For example, during COVID, we have an essential care partners policy. If you're here acknowledging department-wide to the entire organization that we are dealing with this structural, systemic, anti-Indigenous racism where people are seeking care and the institution is not safe for them, why are Indigenous people expected to enter these institutions alone with no care partner? At that point during COVID, you could only have somebody come into the hospital with you if you were a child, if you were under the age of 16, and meanwhile, I'm saying, no, that's not fair. You're saying that there's issues. Let's actually do something about it. And we can change some policies. We can start shifting. You can do step by step. And yes, it is easier to talk about racism. It is easier to acknowledge racism. It is less likely to be gaslit. But at the end of the day, nothing has changed. Nothing really has changed. Indigenous people are still anticipating and mitigating racism. They're still anticipating and mitigating, when do I have to go in? I think about, these delays and this resistance, and it's the institutions just repeatedly showing themselves not to be safe. And I think that we could all look back and just say, I would have done this differently, I would have done that differently. It's the same situation as Brian Sinclair. But none of us would have been involved in that situation, but we all were involved in that situation. We are every single day. And sometimes you hear these really damning remarks, like chiefs of staff saying things like, oh, Brian Sinclair happens every day. But that's like very casually said, as if it's like, oh, I'm frustrated that this is happening. But it's like, well, if somebody was dying of a preventable infection every single day in your hospital, you would immediately address it. You would immediately call in experts in infection control. You would immediately call in a team that understands how the infection is spreading and why it is spreading and why it is killing people. But yet when we have these issues of racism is killing people, it's just said out loud as if you should get a gold star for just saying it. But then you didn't call in the team to address it on a structural level. Mm-hmm. And so I think that, I just keep coming back to, don't say no to Indigenous people when we are coming to the table with solutions. Resource solution.
Yeah, so beautifully well said, and that leads directly to Dr. Lalonde. We have a First Nations man who is head of a hospital, chief of staff. What is different in your hospital? Like, we heard Dr. Shush talking about how we need, policies and procedures. Things have to be different for Indigenous people, and recognizing the fact that there has been two Canadas for so long. What is different when we walk into your hospital? What will we see and feel?
So, my hospital is a little unique, and so I'm not going to use it as the model for Ontario, because we have two reserves that are essentially a large part of the chair of our board is in charge of healthcare for the North Shore of First Nations. So they have their chief of staff is Indigenous as well. So despite being a largely Francophone and English community, there's a very strong Indigenous presence. So I'm actually very privileged in the sense that there's almost a forced requirement to be more accepting. But to speak to Dr. Shush's comments, I think that the answer is and to what you're saying is, how does this change? It starts here. Like, this is just it, right? Since I was very young, my mom's pushed one thing on me. Like my dad was a miner, my mom was about education, and she pushed education on me all the time. And I think that these conversations and having distinguished panels like this that understand the problem and having these discussions, like I don't know if the OMA has ever done this before, but this is the first time I've heard of it. And I don't know how many times these kind of conversations happen in a larger venue, but we're starting to. Your work showing all the stuff that's happened in Thunder Bay. I grew up in these areas 20 years ago. That didn't happen. We didn't talk about it. So the only way things change is we educate and we bring things to the forefront. Like I said earlier, I can't say racism will never happen in my hospital. Of course it will. Unfortunately, that's just the reality of human nature. We all have our inherent biases, and we have to be cognizant of it. But I'm telling you right now, it's less likely to in my community because of the education we've done. Because whenever we do a board meeting, we have a land acknowledgement. We often bring in an elder. We often do these kind of things. I'm the chief of staff, and I was asked to be that by both my colleagues and the board, because I've earned the respect of everybody, and therefore I'm a proud Indigenous physician. So you make changes by making sure that other people understand the problems, acknowledge them, and be aware of them. Because people, I genuinely believe that the greater population isn't inherently bad; they just don't know. And it's unfortunately, ignorance isn't an excuse, and nobody should ever be excused for poor behavior. And like you said, you can't. And like Dr. Shush said, just because you didn't know is not an excuse. It really isn't. But for us, and as physician leaders, and for the greater populace who is educated about this, the more we can get people to realize these things, the more they'll like, okay, well, no, I don't want to do that. I don't want to be harmful. And those who do, well, we have to accept that there's bad people out there. But for the most part, I don't think most people are that. And the more we can educate the populace, the better everything will be, I think.
Big Witch, for your words, and for pointing out the unique structure too of where you work, and the it's enlightening and wonderful to hear the change that's happening in your area in North Bay. Dr. McMurren, I want to ask you quickly, and this is so unfair, I know it's an hour is so tough, but how do you turn the ship around? I mean, like you work as well at the University of Toronto, the massive medical faculty, teaching hospitals abound, yet the Indigenous presence is hard to find. People like yourself and Dr. Shush are making a big dent in, Dr. Smiley as well, Janet Smiley, are in there and fighting the hard fight. But it's a really big mountain to climb. How do you go about making change? I'm sorry, this is such a big question.
It's a beautiful question and an important one. Thank you. And I'll admit that I don't have a straightforward answer or a short one, but I'll try my best.
Yes, in 5 minutes.
Yes, less than that even. So there's room for others. But I think something that feels so important that's coming out of the work that I'm being sort of able to do through the working group for Indigenous physician wellness and joy in work is really calling on institutions to acknowledge the need for equitable practices. So going back to Dr. Lalonde's sharing of that illustration, that the minority tax is very high, and the reality is that there's so much unacknowledged care involved in, I was going to say labor, but I think I would say it's such meaningful and honoring work to be able to support people experiencing difficulty, like medical learners and trainees and colleagues, etc. But it's often not acknowledged as work in a way. The institutions don't see that as sort of promotional material, so to speak, or something that's acknowledged or paid by the organization or the government. And I think there is a need for it to be more than just gums. There need to be teeth. And so that idea of acknowledging the work required to really support Indigenous physicians in the work that they're doing, because there's a lot of work to be done, and it can feel very lonely in settings where there are few. And to speak just briefly to name the experience of Indigenous medical students and learners who are often the only learner in a group, and very either maybe not too sure about naming that they identify as Indigenous, or if they do, being sort of put on the spot to sort of teach the tutor. So I think that's a really important area in terms of supporting Indigenous learners to keep them in programs and well and thriving as best as they can, but also acknowledging the need to at least know that faculty members can cause harm, right? Often by the lack of awareness or the dismissing attitudes. One of the main ways, and then I'll stop, is with the reality that tutors have multiple times recently sort of told their tutor groups that Indigenous content isn't so relevant because they don't really have any Indigenous people in their practice. And that kind of, for me, defines a major issue, right? That as soon as that gets mentioned, it makes me wonder why Indigenous people aren't seeing them or acknowledging that they're Indigenous when they go for care. Not that they're not in their practice, and just the reality that if that's happening in the medical school setting, what are the ripple effects of that? Because learners need to have the ability to practice in a safe way.
Miigwech. In the remaining time that we have left, what I wanted to do actually, and I hope the OMA is not going to be too mad about this, but you had a question for the physicians that I think is a really good idea to ask them, because I think this is like a unique opportunity that the OMA has, an all Indigenous panel, which is so wonderful. So I want the people listening, the audience, to hear the voices of the panelists. And so I would like, if it's possible, for every panelist to spend 1 minute answering the question that the OMA posed. And that is, if everyone listening, if they could do something, change, one thing, what could they do to change after listening to this panel? I believe that was the question that I don't want to waste time by pulling it up on my, but I think it was that was the essence of the question. If you could give one message to your audience listening, and they're mostly not Indigenous, what would you say as a take-home message? And I'm going to start with you, Dr. Lalonde, because I see you first.
I said perfect, because my message is very simple and very easy, and I touched on it very briefly. Educate yourself. The more you learn about other cultures, whether it's Indigenous or not, the more you're going to appreciate them and understand them and care for them. The more you understand the plights that our people went through and the reason why these generational traumas are. Like, I was going to talk about generational traumas and just ran out of time, but there's a reason why we need to educate people about this stuff. And if you can understand where we're all coming from and why there's a challenge and why there's the gap, then that's how you bridge the gap, is with knowledge. And so that's what I would say. Educate yourself in everything you can. And then from there, you'll have compassion, I'm sure.
Miigwech. Dr. Lafontaine?
Building on what Dr. Lalonde just said, I think if I could have one thing from colleagues, it's take some time to reflect on what you actually think about Indigenous peoples. Like, have a personal, blunt, honest conversation. There are a lot of beliefs that we pick up through the things that we saw growing up, through the things that we experienced in school, our own personal interactions with First Nation, Métis, and Inuit people. And then in training, there are behaviors that we see staff do. There are situations that we've been trapped in. And all those things have aggregated into positive or negative, dispositions towards Indigenous patients. And unless you come to grips with yourself and what you believe, you can have all the education in the world and it won't change anything. And so if I could have one wish, it would be for people to look and take a really hard look inside about what you believe, and then decide if you still want to believe that.
Wow, that's beautiful. Dr. Shush.
That was beautiful. I would also say, look at yourself, but also imagine that an incredible investigative journalist like Tanya might one day come looking at you. And what are you going to have? Are you going to be proud when your organization is picked apart? Are you going to be proud when your patients are interviewed? Are you going to maintain your career and your license? Are you going to have an illustrious reputation? What are you ready for? What are you ready to answer to? Are you doing the work? Are you making the changes? Are you looking at your policies? Are you listening to the community? Are you sharing resources? Are you hoarding the resources away from the Indigenous community ongoing to just create the systems that are still the same? What are you actually doing to change the status quo? Because it is just so important that we move past the good intentions and the acknowledgement into true actions, and that can start now. I know. So thank you.
Miigwech. Dr. McMurren.
I'll be so quick to say that if we consider like a trauma-informed lens, thinking of intergenerational trauma, that symptoms, especially things that scare us, so people's behaviors or actions or situations that might make us feel overwhelmed or frightened or sort of motivated to try to fix something that isn't necessarily ours, to fix on behalf of somebody. I think that respecting symptoms as important to notice, and to not see the symptom as the person, to sort of see as much as possible, to separate a human having experiences and the symptoms they're facing, and then asking how we're either contributing to those symptoms or how we can be part of addressing them in a respectful way, where the person with the symptoms is the person in charge, not us.
Well said. Beautiful. I wanted to make one quick comment before we close and thank everyone, and thank very much our panelists for being here. And Dr. Lalonde, you said briefly that you were preparing to speak about the effects of intergenerational trauma. And I think it's pretty safe to say that all of the stories and the realities that we brought forward to you tonight, from all of our perspectives, comes from intergenerational trauma, from the effects of colonization, from the Indian Act, from the effects of Canada building a universal medical healthcare system, but leaving Indigenous people out of that system, very much separate of that system. And that could be a whole other hour discussion, actually, about the Canada Health Act, about FNIB. We could go on and on and on, but we're not. But know that everything that we're talking about now is a net effect of those traumas and of colonial policies that Canada has seen. And so this is such a fitting talk to have right before we have the National Day for Truth and Reconciliation tomorrow, because these are things that we could all reflect on and think about. And with that, I see that it is 7:00, so I really want to say Chimigwich, Dr. Lalonde, Chimigwich, Dr. McMurren, Chimigwich, Dr. Lafontaine, and Chimigwich, my friend, Dr. Shush. I admire you all. You're fighting the good fight, and all the work you do is for all of our people and for our children. So go forth and have a good reflective day tomorrow. Take care.
Thank you.
Thanks, everybody. Have a good night.
Thank you.